Well, hello everyone, and thanks for having me today to present. My name's Ethan Nguyen. I'm one of the glaucoma surgeons and medical retina specialists working across Sydney and across Greater New South Wales. I recently came back a year ago from the UK, where I spent about 18 months training in some new forms of glaucoma surgery. So I'm quite excited to have this opportunity to explain the different types of surgical options available and answer some of your questions out there. So I thought I'd start off by just talking a little bit about the different types of glaucoma surgery available, because we can't really talk about why we choose the different options without at least knowing what the options are. And we'll take it from there. So this is just a quick overview of what the talk will be about. So we'll very quickly recap on what glaucoma is. Hopefully most of you have had a pretty good introduction to all of that already. But we'll briefly canvass that, and then we'll move on to the traditional types of glaucoma surgery, including the pros and cons of each. We'll then talk about some of the newer minimally invasive techniques, which I'm sure many of you may have come across or heard about through your specialists, and which are increasingly becoming much more popular. And then if there's a little bit of time, I might talk briefly about what's on the horizon, depending on how we go for time. All right, so let's quickly go through what glaucoma is again. And there's two main things as patients you really need to understand about glaucoma. And it really is about, firstly, the optic nerve, the nerve in the back of your eye. That's what your specialist is always looking at when they're peering into the back of your eye, because it's a disease of the optic nerve. And that's that cable that transmits all those signals from your eye to your brain. It's like the HDMI cable or the USB cable that plugs into your camera, that travels to the computer box, if you will, where all the seeing is done. And glaucoma is a disease of that nerve or of that cable. And when we look in the back of your eye, we can see that it's starting to degenerate. And there's lots of factors that affect why that nerve dies over time. But the main thing, and the only thing that we can really control, is the pressure. So really, glaucoma is a disease of pressure, even though if you look more into it, there's a few other factors at play, but really pressure's the big factor there, and the one thing that we as doctors can control for our patients. And we know that if we increase the pressure in anybody's eye high enough, it will start to cause death of that nerve. And then there's a healthy range that we want to keep our patients in, where we can maintain the nerve so that it continues to function over the span of the patient's life. Normal pressure ranges about from 10 to 21. And so if you've got pressure above that, then we need to start treatment on you to try and get it to a healthier and safer level. There are, however, conditions where or circumstances where the pressure can be only towards the upper end of normal, or even the pressure can be normal to begin with. And in those scenarios, it can be a little bit more challenging. But what we do know is that regardless of where you start off, if you're starting to develop glaucoma, reducing the pressure in your eye, in most instances, either slows down or completely halts any progression of the disease. So the aim of any treatment in glaucoma, be it surgical or not, is to keep the pressure low, to protect the nerve at the back of your eye, and hopefully maintain good, useful vision for the rest of your life. Now, if you look at that image that I've got on the right there, that big ball of jelly towards the back of the eye behind the lens, that part's fairly static for most of your life, on a day-to-day basis. That doesn't change very much. But the front component, which is in front of the lens there, you can see the little arrow towards the bottom. Sorry, I don't have a pointer to really point out exactly what I was hoping to point out. But effectively, fluid is made in the front chamber of your eye, and it circulates upwards and then drains into that little angle. You can see that arrow coming out through the pupil and then back down where that blue liquid is at the bottom in the front chamber. It drains into the little angle of your eye there, into that little canal. And that canal runs 360 degrees around that segment of the eye. And on the left of the diagram there, you can see that I've got a little bit of a close-up to it. Deep down in that angle, there's all these little perforations, and they're like the opening of the drain. And all the fluid collects into that drain and runs out into the little blood vessels and is carried away from the eye. And as we get a little bit older, for various reasons, either the opening of that drain can start to become crowded and tighten up, or the actual drains underneath there where we can't really see into, they can start to block up over time, a bit like, the drain in your sink gets a little bit tight over time. And that leads to increased resistance, and that leads to a buildup of pressure in the eye, because the tap continues to flow at the same rate. So the eye continues to make fluid at the same rate. But in order to get that fluid out at the same rate across a tighter drain, it needs to increase the pressure to pump that fluid out. And then that pressure is transmitted backwards up against the nerve in the back of your eye, and that then leads to glaucoma. And that, in a nutshell, really is what glaucoma is. It's about a blockage of the fluid getting out of the eye, leading to high pressure, that pressure transmitting back and affecting the nerve in the back of your eye and causing you to slowly lose vision, usually from the periphery upwards and eventually into the center of your vision, where eventually your brain starts to pick it up. The important thing to note about glaucoma is that any vision you lose or any part of the nerve that dies, we can't really get back for you. So it's about trying to intervene early and stop any disease progression, before it becomes significant to the patient. So with that all in mind, let's move towards the types of surgery that we can offer in glaucoma. So this is a little bit of a timeline about how most glaucoma surgeons think about your glaucoma. And when you're first diagnosed on the left, sometimes we might just watch you. And there's lots of reasons why we might do that. We don't always start treatment right away. Sometimes we're not sure you have glaucoma, or other times we think it's progressing at a very slow rate and you don't need any treatment yet. Like all things in medicine, the risks of starting a treatment have to sort of be substantially the gains of treatment have to significantly outweigh any disadvantages to starting them. And then when you start treatment, the first thing we tend to do is offer you either laser or medical treatment with drops. And most of you would be fairly familiar with that. And I've got arrows there pointing in either direction, because sometimes people will start with laser and other people will sometimes start with drops. And there's lots of reasons for that, and that's probably beyond the scope of my talk, so I won't get into that at the moment. But suffice to say that you'd start with either of those two things before moving towards surgery, because they're obviously the more conservative approaches. But let's say you've failed all that now, or you can't tolerate the drops, and now you're needing to consider moving towards surgery. Then what are the types of surgery available? And on the right of that diagram, you'll see that I've got two major categories there. One is on the far right, the traditional surgery called filtration surgery. And they really break down into two main types. One is called trabeculectomy, and the other is type of tube implantation. And there's various types of tubes, and I'll go through those in a moment. But these have been around for a very long time, and trabeculectomy has been around for about 50 years or slightly more than that. So we've got a lot of experience in it, and it has been modified several times throughout the decades, but it's fairly tried and tested. And then more recently, in the last decade and a half or so, we've developed newer, more minimally invasive techniques, often referred to as MIGS, which stands for minimally invasive glaucoma surgery. And that's a big bucket of different things, and they can start from very small things, like the things at the top, like the Eye Stent or the Hydrus, or something that's now recently been recalled called the CyPass, to slightly larger devices like the Zen or the PRESERFLO, the PRESERFLO being particularly new, only available since about March this year. And there are always new devices coming onto the market as well. And as glaucoma surgeons, it's important that we sort of try and stay on top of that and offer them to our patients when they're appropriate. So we'll just move forward again. And so before we consider what type of glaucoma surgery to choose for our patients, there's various things that we need to take into careful consideration. And the first one is probably, what's the target pressure? What sort of pressure does the patient need to stop their glaucoma from advancing or progressing? If the pressure is very high to begin with, you often need fairly big reductions, whereas sometimes your pressure is only a little bit off from being where it needs to be. And so then you might only need a very small drop in the pressure. It might be that you might have some sort of surgery where it's an adjuvant to the drops you're currently taking, and the aim is not to get you off the drops completely. And then other times it may be that you can't tolerate the drops, or that you need such a large reduction. The aim is to give you a very large reduction in the pressure and then get you off all of the drops, although in time perhaps we may reintroduce one or two of the drops further down the track. Other things to consider: how quickly does the surgery take to have a maximum effect? Some surgeries can take weeks to months before they become mature and give you the pressure reduction you need, and others are fairly instantaneous. And if you've got someone with rapidly progressing glaucoma, perhaps you don't have the time to wait as long. So you may need to pick a surgery that gives you that pressure reduction much more quickly. But most importantly, you kind of need to consider the patient that's sitting in front of you, and that can vary. That can mean that you need to look at their stage of the disease. So if someone's got very advanced glaucoma, you often don't have the opportunity sometimes to try the smaller things first, because the pressure reduction may only work for a short period of time, and then very quickly you'll need to move on to something that reduces the pressure much more substantially. Or the patient might be significantly older and have a lot of difficulty coming back to the clinic on a regular basis, and some types of surgery demand much more frequent follow-up, and so then that may limit your choices for what types of surgery they're capable of having. Many of our patients are on multiple types of medications, including blood thinners, and various types of surgeries also do worse when you're unable to stop your blood thinners, or are much more challenging to perform. So all these things come into play when you're considering the patient that you have in front of you, and you're trying to select the best surgical option for them. Obviously, with any sort of surgery, we're always thinking about the types of failure that can occur with the form of surgery that we perform, whether they be early failure or sometimes late failure. If you have a very young patient who might need that surgery to survive for 20, 30, 40 years, that's very different to someone who might be in their 90s and just needs the pressure to be well controlled for the next 10, 15 years. So that also plays into it greatly. But really, at the end of the day, the real objective for us as eye surgeons really is to maintain useful vision for our patients. That really is the end game. If you've got one eye with good vision and one eye with poor vision, that might change very much the metric. If you've still got a lot of vision left and you're no longer driving, that might be different to someone who's very young, who is still working in their 40s and needs that vision to last them for the next 4 or 5 decades. So all that really plays into what type of surgery you want to choose and what sort of risks you're prepared to have your patients accept. And you do that in consultation with the patient sitting in front of you as well. All right, so we'll move forwards. And before I start and talk about the different types of surgery, this diagram is really just to remind you that at the end of the day, glaucoma surgery really is just about fancy plumbing. What we're trying to do is get the pressure down in your eye because the drainage in your eye is not working terribly well, and we're trying to get in there and provide different outflow channels to replumb the eye to get the pressure back down to a healthy state. All right, so with that in mind, let's talk about the traditional types of surgery first. And the one that's been around the longest is the trabeculectomy. And that's been around for, as I said earlier, for at least 50 years, probably a little bit more than that. And what that really entails here is you'll see that there's a diagram of the eye there sort of facing downwards. Traditionally, most trabeculectomies are done at the top of the eye. And what we do there is the white coat of your eye is covered by a layer called the conjunctiva. It's like a slightly thickened glad wrap layer, if you will, like the skin of the eye. So we make a cut and we reflect that backwards to get access to the sclera, which is the coat of your eye. It feels a little bit like hardened egg white, boiled egg white. And it's roughly about 1 millimeter thick, give or take, depending on the location of the eye. What we do is we make a little scleral flap or a pocket, if you will. So we dissect down to about half the thickness, so about 1/2 millimeter, and you do that by hand. And you cut this pocket and you reflect it backwards towards the clear window of your eye, the cornea, and then you make a little hole and enter into the front chamber of the eye. And through that, fluid egresses out and then you put the flap back down, and then you suture it down partially. And that creates a little bit of resistance so that you just don't have an open hole leaking fluid at a very high rate. And everyone does it slightly differently, but basically you can put a couple of sutures down to tighten that flap, and then you pull that clear layer, the conjunctiva, back over and close over it. And then in the next several weeks, as the eye is healing, those sutures that you'd use to close down that flap, you can either sometimes laser to break and release, or you can pull out. You can make them releasable sutures, and they're very tiny, so the patients don't feel them. They're thinner than a strand of hair on your head, and you can pull them out through the cornea in the clinic on the slit lamp through the microscope with a bit of practice. And that adjusts the tension on the valve and helps us modulate the pressure. And what you effectively end up with, if you look on your right there, is a little bleb, a little blister underneath the eyelid there. You can see on the top picture, that one's a little bit to the top right-hand corner, or the patient's left-hand corner. And then on the bottom picture, that bleb is right at the 12 o'clock position. So fluid flows out through that trapdoor into a little pocket underneath the skin of the eye, the conjunctiva, into a little blister. That provides a little bit of resistance, and hopefully that gets your pressure down to where we want it, which is, in most instances, we want it sitting around 8 to 10 millimeters of mercury. I tell all my patients that half the work is done during surgery, and the other half of the work is done by myself and the patient in the next 3 months. It's a long recovery process because a lot of it is dependent on how your eye heals. If you heal not enough, then the pressure ends up being far too low. And if it heals too aggressively, which used to happen a lot in the past before we had anti-scarring medicine, then it all scars up and it stops functioning, and you're back to where you started, basically. Everything flattens out and there's no drainage anymore. So getting the eye to heal absolutely correctly is partly your surgical technique, is partly the drops and everything you use afterwards to modulate the healing. And then a lot of it is also just dependent on the patient. So we know different ethnicities heal at a different rate, and different people, humans being humans, just respond differently to the surgery performed on their eye, even if the surgery is identical between patients. So as I said, a lot of that work is done in the aftermath of the surgery, and usually by about 1 to 2 months out, the eye starts to stabilize out, and we reduce your drops significantly, and then we sort of monitor from there afterwards. Once you have a bleb in your eye, it's a little bit of a lifelong thing. So you will basically have a lifelong relationship with your glaucoma surgeon, because even if it's functioning very well, in the next several years, it can fail, and it can even fail decades later. And it can fail in various ways. It can scar down and stop working. It can leak and start to thin out, and the pressure can drop precipitously, or they can become infected. There's lots of different things that can happen to them. So I tell all my patients that once you have this, it does change your eye, and you need to have an ongoing relationship with your glaucoma surgeon, who needs to keep a careful watch on it. And I usually give my patients a variety of instructions on what to look out for in between visits as well. And so these are just some of the problems that I spoke about earlier in terms of having a trabeculectomy, that they can scar, they can leak. Some of these can happen early in the course of the recovery, and some of them can happen much, much later. We won't go into that in too much detail because I need to move on in the interest of time. So the next major surgery is something called a tube implantation. And there's been a variety of tubes that have come onto the market over the last several decades. The latest one that's only recently come out is called the Paul tube. That's there on the left. But the Bearvelt tube there on the right, that's been around for quite a long time. And then there's the Almed valve. That's a valved tube. I won't go into too much details about the different types of tube. They all function in a fairly similar fashion. You'll see that there's a tube basically attached to a plate. And then if you go to the next slide here, you'll see that plate is normally inserted behind the muscles in your eye. where they're then secured to the sclera, the white coat of the eye, with some sutures, and then that tube travels forwards and enters into the front chamber of your eye, and then fluid is then egressed out and onto that plate. And all of that is, again, covered by the conjunctiva, the skin of your eye, and it forms a big blister much further back underneath your eye. I'm just on call, so I'm just getting a phone call there. We'll just ignore that. And then hopefully that addresses, regulates the pressure and gets you down once again to a pressure around 8 to 10. There's often a little patch of a donor sclera, which is harvested from a cadaver that we normally place over the tube itself, and that just stops it eroding with time. Because sometimes as it sits there underneath the skin of your eye, the conjunctiva, as you move your eye around, it can cause the tube to erode after many years. So we normally place a little bit of donor sclera on top of that, just to act as a little bit of an abrasive guard, if you will. So what are some of the pitfalls of the tube? Well, similar to the trabeculectomy, they can fail, they can scar over time. Sometimes initially, if the drainage is too aggressive, you can end up with very low pressure, and that can also be a problem for patients' vision. Leaking is less of an issue as compared to the trabeculectomy that I showed you earlier. They don't tend to get as infected as frequently, but the main problems with them are a bit similar to the trabeculectomy, is that over time they can cause problems where they can scar up and the pressure becomes too high again. Or particularly in the early phases, if you don't manage them appropriately, the pressure can be too low. One of the other problems with the tube in the eye is that because it sits in the front chamber, it can sometimes rub up against the cornea, the clear window of your eye, and that can cause the cornea to fail over time as well. Again, depending on your surgical technique and where you place it, there are ways we can basically try and mitigate that. Some of that is also dependent on the health of your cornea before surgery. All right, so let's move on to the minimally invasive glaucoma devices now that we've spoken about all these really big traditional types of surgery, because as I've indicated to you already, they're big operations. They take a long time to recover from, and they do have problems down the track as well. So because of all that, in the last sort of decade and a half, people have come about with less invasive forms of surgery where the recovery is a lot quicker, and there's less impact to people's vision in the first 2 to 3 months. It's just a little bit more desirable for patients. And these surgeries can be performed either by a glaucoma surgeon, but some of them, particularly the one I've got here, like the Eye Stent, they may even be performed by many of our generalist colleagues as well. So in some ways, the access to this surgery is also more widespread, which is good for patients, particularly those living in rural settings, etc. So I'll start with the Eye Stent, which is probably one of the most minimally invasive devices. It's a 230 micron plug, basically, that we insert into the drainage angle of your eye, and it's best performed at the time of cataract surgery. It can be done outside of cataract surgery as well, so you don't have to have cataract surgery, but the most common time you'll see this one performed is at the time of cataract surgery, and there's various technical reasons why it's more convenient to do it at the time of cataract surgery, partly just because the space is easier for the surgeon. But it's a fairly safe technique. It causes very minimal trauma to the eye and carries very little risk compared to most of the other types of glaucoma surgery. Its main disadvantage is that it doesn't tend to lower the pressure anywhere near as much as your traditional types of surgery. And this can be said for a lot of the minimally invasive types of glaucoma surgery. The general rule is the less risky the type of surgery, the slightly less bang for buck that surgery tends to afford you. And traditionally, most of the studies looking at the Eye Stent, for example, would show a drop in pressure of about 2 to 3 millimeters of mercury, which might be enough for a lot of patients who only need that little bit extra to get over the line to reach their target pressure. But for those patients who are sitting on pressures of 26, 27 on multiple drops, who really need to get their pressures down into the mid-teens, this is not the device for that patient. I get a lot of patients asking me, can they have this when they've got very advanced glaucoma and needing a trabeculectomy? And the quick answer to that scenario is no, it will not get your pressure down anywhere near enough. And so really you're just faffing about, and we would worry that you'd be losing a lot more critical vision in that time, and you really need to move to more traditional big surgery. But this surgery is good for somebody who's maybe taking one drop and might need an additional drop added. It might avoid them moving on to having that second drop, or perhaps if they're only needing one drop, maybe they can come off that one drop after surgery. And there's lots of benefits to not being on drops. So this is the sort of surgery I tend to offer my patients if they're about to have cataract surgery anyway, and they've got a bit of glaucoma. Well, then I normally stick these in at the end of cataract surgery. It only takes another 10 to 15 minutes. And potentially it either might stop them from having to use their drops, or maybe avoid them needing further tracks down the track. So I think I've got a little diagram over there. So that's usually the injector comes with 2 stents, and they sit in the angle of your eye there. Your surgeon has a special way of accessing that angle on the microscope, and we just inject them in at the end of cataract surgery. The stents are now in their 3rd iteration, so and I think there's a 4th iteration soon to come out. I think the company's now working on a stent that might even have some of the traditional glaucoma drops you use embedded in it that might exude the drug for about 2 years. So we're watching that space fairly carefully, but that might be quite promising. And there the stent is again sitting inside the angle of the eye, bypassing the block drainage channels and going into the veins in your eye that normally collect all the fluid. This is a similar device. It's slightly larger and slightly longer, although it's about 8 millimeters in length, but the actual opening of the inlet's about 250 microns, so about 1/4 of a millimeter. And that is placed very similarly into the angle of the eye as well. So you can see there's a little injector there being placed into the angle of the eye. Let's go back there. And then it is then injected and passes and slides into the angle of your eye. It affords a slightly higher pressure reduction than the eye stent that I showed you just previously, but it's technically a little bit more difficult, does cause a bit more bleeding, and does carry a slightly higher risk profile. But the mechanism is very similar, so you're still trying to bypass that all those block drainage channels and get into the space behind it where all the big veins collect the fluid. This next device is called the Zen, and this has been out now for several years. Depending on where you work, it's not available everywhere. Not every surgeon does this device. It's a bit similar to the tube I showed you in terms of the big glaucoma surgery, but it's a much smaller tube. It sits in a very similar space though. So it sits in the front chamber of your eye and then comes out into this, the space underneath the conjunctiva and forms a little bleb. It doesn't have a plate attached to it like the traditional tube surgery that you saw. And the advantage of this particular one is that it's injected into the eye through the cornea. So it's a much smaller operation than the traditional tube surgery and much quicker. And so the recovery is much more, much faster. One of the other advantages is that I didn't mention this earlier with the tube surgery, but usually with the tube surgery, there's a very high risk initially that the pressure is very low for the first several weeks. So we tend to tie it off and have it not working for the first 6 weeks while everything's healing down. This tube doesn't have that problem because it's a much smaller tube. And so because of that, it can start functioning straight away. And so that's one of its major benefits over the tube where, you saw the plate earlier. Because of the way it's inserted, however, it does have slightly higher scarring rates. And some surgeons have felt that it tends to scar up a lot more quickly and needs a lot more manipulation in the clinic. And some people have abandoned using it. But in the right patient population, and some of the newer iterations of this device have been more successful, it can still be a very good alternative as well. And so that's just the same tube being injected. You can see that the needle passes into the angle there and then comes out underneath the conjunctiva, the skin of the eye, the tube is then injected into that space, and then the needle is withdrawn and the tube is left in place. And then lastly, this is the PRESERFLO. So this has only recently been on the market since March this year, but they've been using it in the UK and Europe now for about 5 to 10 years. There's a bunch of large studies that have come out in the last 2 to 3 years, and I authored one of them recently when I was in the UK, where we had data for about 18 months worth, and I did about 60 of these myself. And this is very similar to the tube I just showed you earlier, but the way it's been constructed is slightly different, and its insertion is slightly different. So rather than injecting it into the eye, you have to do it from the outside in. So you have to cut the skin, the conjunctiva of the eye open, reflect it back, and then insert it into the front chamber. So it's from an out to in approach rather than an in to out approach, as you saw with the previous one. And this has various advantages in terms of the healing and the scarring profile. And again, it's about 8.5 millimeters long. Oops, sorry, going back there. And 350 micrometers wide, but the actual internal lumen is only 70 microns. So very, very small. Someone's done some very clever calculations to work out that that's the amount of resistance you need to get the right pressure in the eye. And the studies that have been done so far, including the one that I authored with some colleagues, that shows that it has fairly comparable results in terms of getting your pressure down to the traditional trabeculectomy, with maybe a slightly higher scarring rate, only slightly. But it's substantially less invasive than a trabeculectomy, and people's visual recovery is much, much quicker. So this is showing a lot of promise at the moment. There are certain types of glaucoma it's not as good for. If you need a pressure that's very, very low, well below 10, then it perhaps is not the right device. But if you need to get your pressures in sort of between 10 and 20, which is where most normal physiological pressure sits for most people, it's a very good alternative, and it's slowly widely becoming available. So we're watching that space carefully, and I have started putting it in several of my patients with fairly good results thus far. And there you can see it sitting again underneath the conjunctiva on the just above the white coat of the sclera of the eye. And then it enters into the angle and just sits just behind the cornea. And you can often see it. There's a picture to the right there. You can see the little tube sitting there, to the top left-hand corner in the eye. And there's the picture on the top shows the device sitting on somebody's finger there, how small it is. So they're the common devices on the market at the moment. There are some other ones. They all work in fairly similar fashion, but these are the most popular ones and the ones you're most likely to be offered by your glaucoma surgeon, and in some circumstances like the Eye Stent, even by a generalist or cataract surgeon. So the thing to say at the end of all this is when it comes down to treating glaucoma, you need to know various things. First of all, what type of glaucoma the patient has, because that does sometimes influence which device is appropriate or which type of surgery is appropriate. You need to know the target pressure that you're aiming for. As I suggested to you with the last device, for example, if you need a pressure below 10, that device is probably not the one for you. You might be better off with the traditional trabeculectomy. And then after all of that, you can pick, the sort of treatment or the type of surgery that the patient should have. But after all that, really what you need to consider is the patient sitting in front of you, and what they want. How long are they going to need to have this pressure low for? What's the age of the patient? What are the medical comorbidities they've got? How mobile are they? How frequently can they come to your clinic? All these things weigh quite heavily when we're trying to make a decision as to what sort of surgery a person should have. All right, so I think that's pretty much the end of my talk. Look, I've just quickly included this picture to make a point. Most of you will recognize that picture at the top there being a Boeing 747. That's the big jumbo jet that most of us have flown on for most of our lives. That's been around since 1969. And when it was first designed, it was actually designed as a freighter plane. And that's the reason why there's a big hump on the top of the plane, because the pilots would sit on top and all the cargo would be loaded through the nose cone. And the people at Boeing thought that the plane would very soon become obsolete because the Concorde was being developed by the British and the French at that time. And so they all thought that they would build it as a freighter plane and use it as a commercial plane just for a short period of time and develop their own supersonic jet. But it quickly became apparent that supersonic flight was both uneconomical and unfeasible. And to this day, we still fly subsonic when we travel abroad, unless you're a fighter pilot. So I put this slide up just to remind us that there are lots of new and exciting things that are coming out all the time in the world of medicine. And as glaucoma surgeons, or as surgeons in general, we're always excited to see them, and we're always looking to new ways to improve our patients' care. But we also have to be a little bit conservative about jumping on board too early with new devices, because they don't all stand the test of time, and occasionally things have been recalled or ended up not working or causing more problems than the successes that they've promised. And sometimes the old and tried and trusted techniques are still the best options available, and we shouldn't sort of be too quick to write them off. Okay, that's basically my talk. Thank you. All right, so we've got some questions here along the side. Let me just have a look at them and see if I've answered them already through my talk. Okay. Okay, so the first question here, someone said, how long after surgery can eye pressure start to increase again? That can vary. So you can have very early failure. Within a week or two, they can scar down. If the surgery hasn't been done particularly well, sometimes, day 2 or day 3, they can stop working. Now, we do put releasable sutures in place. And so, for example, with the trabeculectomy, so usually at week 1 or week 2, we may pull those adjustable sutures and try and encourage the bleb to function more rigorously. The risk is that, if you pull them too early, sometimes the pressure plummets, and that's also a problem. A pressure of 2 can be quite catastrophic for an eye for various reasons. So trying to get the pressure on point is difficult, which is why, for example, the Ahmed valve designed by Ike Ahmed has a valve inside of it to get you that perfect pressure, if you will. But like all things you put in the human body, if it has a valve, it sometimes then clogs up years down the track. So the answer is it can fail very quickly, or it can fail 3 months down the track, 6 months down the track, 10 years down the track. And the failures at different points can happen for different reasons, and the way you manage them are different as well. So which is why it's important to see your glaucoma surgeon to try and tease that out for you and sort it out. It's not uncommon that during the first 3 months, we may manipulate your surgery on the slit lamp here in the clinic. So we may need to needle it. Sometimes we'll take you back to theatre to needle it, or we may even inject some anti-scarring medicine here on the slit lamp, something like 5-FU, 5-fluorouracil, or mitomycin C. So I've got another question here. Can stent implants in the eye overcorrect the eye pressure? No. So the stents, the eye stents, for example, definitely can't overcorrect. You can't get low pressure from the small stents. The usual problem with the stents is that they don't drop the pressure enough. We're really aiming for maybe a 3-4 millimeter mercury pressure with a stent at most. So there's no risk at all with having a low pressure eye with stents. But with big tubes, with trabeculectomies, definitely you can get very, very low pressures. If you get too much flow at the start, then it decreases healing over time, and then you end up with a chronically low pressure eye, and that's very problematic and hard to fix. But yeah, the converse is if you make your hole too small, or if you encourage too much healing at the start, then you end up with the opposite problem. So it's a little bit of a fine art to it, basically. Are there long-term adverse side effects with continuous use of glaucoma eye drops? Would it be more beneficial to have surgical intervention instead of discontinue eye drops? That's a really good question, and this is also a contentious question. So it depends on if you're someone who is big on early surgery or big on late surgery. And at the end of the day, if someone does a lot of glaucoma surgery, they're more likely to be able to offer you surgery sooner. For people who may need to refer you on, sometimes they're more prone to obviously using drops for as long as they can. And sometimes we are referred patients quite late. And the difficulty with late surgery, number one, is that you've lost a lot of vision. So therefore, there's less vision to preserve. Obviously, if you're down to your last 10 to 20% of vision, then that's all we've got left to save. But the other thing I should mention is that, when you've got a very sick eye and it's down to the last 5 to 10% of vision, the fluctuations in pressure during surgery can actually come and snuff off the rest of that vision. One of the biggest risks to doing surgery on an eye that's only got 5 to 10% vision left is that you can chalk out that little bit of vision just by doing the surgery, and then the patient comes back very unhappy because they think that the surgery has ruined their vision, whereas in fact, the eye was not really capable of tolerating that surgery anymore, or sometimes it's just catch-up disease. So what we see in your eye today is still is still mirroring the effects of the pressure maybe a month or 2 or 3 months ago, depending on what the pressure is. And so you might do successful surgery, but the eye continues to deteriorate anyway over the next 2 to 3 months. And the patient thinks that the surgery has sort of ruined their vision. That's the difficulty with glaucoma surgery, is that you never improve anybody's vision. You tend to drop it initially, and then it comes back to where it was at best case scenario, So it's tricky. It's a difficult operation to sell, and you have to really inform your patients that what you're trying to do is maintain that the vision they've got now, because if we leave it, it will eventually eat into the rest of their vision. It's just a question of when, but almost certainly you're only doing surgery because you can see there's clear-cut progression in their visual field test. And also, and to answer that question in a little bit more detail, what are the disadvantages of drops? Look, generally speaking, if you can use, so drops have various disadvantages. The first is obviously, most of you who are on drops will know that for some people they can cause allergy, irritation, dry eye, red eyes. There's the need for compliance. So studies have shown that if most people start out on one drop, but the moment you add a second drop, the compliance rate goes down substantially, and people are missing drops, several times a week or whatever it might be. And but once you start doing that, then you start getting fluctuations in the pressure, and that will lead to some degree of long-term damage as well. So there's also the cost of drops over the lifetime of the patient. And then the last thing that a lot of people don't think about, particularly if you're not a glaucoma surgeon, is that drops affect the conjunctiva, or the surface of the eye, quite substantially, particularly in people who get very red eyes on the drops. And the longer they're on those drops, the more it sort of changes the profile of that conjunctiva, so that when it comes to doing the surgery, when you handle that tissue, it behaves very differently. It's much more prone to ripping and tearing when you do the surgery, which makes it more challenging. It means that when you then finish the surgery and try and modulate that healing phase, sometimes they scar a lot more aggressively too. So in someone who's got really bad red eyes on drops, we try and get them off the drops quickly and do surgery a little bit sooner, because we know that leaving them on it for a long time can make the surgery much more challenging down the track. So but as you've probably also heard from my talk, the surgery also carries a lot of risk and a lifelong need to have that surgery managed, and even good operations that last 10 to 20 years might fail in the 3rd or 4th decade. So in some ways, the longer you can stave off surgery, the better as well. So a very good professor of mine who I trained with said to me that glaucoma surgery, or glaucoma in general, is a little bit like actuarial studies. It's about risk mitigation. You're really trying to do the least amount to the patient as you can, to keep as much of their useful vision as possible for the duration of their life. So if you've got someone who's losing vision at 2% per year, but they're 97 and they're not driving anymore, or 93, you don't have to be quite as aggressive as that other patient who I've got in front of me just the other day, who's 35, who's lost 80% of his vision in one eye and 40% of his vision in his other eye. Whatever I do for him needs to last and be sustainable for him for the next several decades ahead. And everything you do, every surgery you do, takes up some real estate and affects what sort of surgery you can do down the track, so that even if it's successful the first 2 decades of his life, I'll need to think about what happens when that fails. What will I do when he hits 60 or 70? Because he's only 40 at the moment, right? So it's almost like playing chess. You're always thinking about every move you make, what are the subsequent moves you can make further down the track for this patient. So hopefully that answers that question about drops and when to intervene with surgery. In the case of advanced glaucoma, can micro shunts control spikes in eye pressure better than eye drops? Yeah, look, that's a good question too. So one of the benefits of glaucoma surgery, look, sometimes we get patients who come in and their pressures look good, and we can't figure out why their vision keeps getting worse. Sometimes that's because the eye is so damaged that even a normal pressure is no longer good for it, and it needs to have a pressure below 10, which drops cannot achieve. We know that. So realistically, the only way you can get a pressure below 10 is to have surgery, and usually that's with big surgery. Little shunts and things, they're not going to do that. You need a trabeculectomy or a tube operation to get your pressure below 10. And so, in that sort of scenario, perhaps that patient's getting worse because they just need a much, much lower pressure. Sometimes they need they're getting worse because perhaps their pressure is good in the clinic, but they're getting fluctuations in the pressure at home. And this can happen for various reasons, because we know there's a diurnal variation to the pressure. It tends to peak in the early hours of the morning around sort of 4 a.m. But then also sometimes patients, they may be missing their drops here and there. They may be starting to develop arthritis, like some of our older patients who then can't use the drops and get them in their eye. Sometimes I'll ask the patient to demonstrate how they're putting their drops in, and occasionally you'll see that some people are completely missing it. It's not going in their eye, but they're just not aware of the fact. We don't always have the time in our clinics to spend and educate our patients on how to get the drops in effectively. Maybe they're not waiting 5 minutes between the 2 or 3 drops they need to take, and so they're washing one drop out with the other. So there's various reasons, and when you do surgery, you can avoid a lot of those pitfalls. The other thing that's been shown in studies, that surgery gives you a good plateau pressure. So your pressure is then stable throughout the entire 24-hour period, whereas with drops, even though you reach what's called a steady state level of medication in your system, you still get a bit of a fluctuation in the pressure, and that can also lead to damage of the nerve itself as well. So there are some benefits in having surgery, but traditionally speaking, these are the slightly bigger operations. So the trabeculectomy, the Bearvelt tubes, maybe it's like something like the micro shunt or the Zen, but things like the Eye Stent and stuff, they're a bit small. I'm not sure they would plateau your pressures out that adequately. So hopefully that answers that question. So someone here has said, I have, from Gail Clark, I have normal pressure glaucoma and I have an allergic reaction to some drops. I now use the Zaga, which are suitable. What level of pressure will dictate when a trabeculectomy will be necessary? So normal pressure glaucoma is when you have glaucoma and the pressure is somewhere between 10 and 21, because that's defined as normal. And normal is obviously taken out a population bell curve of 2 standard deviations or whatever. We know from studies some people can have a pressure of 25 and never get glaucoma, and other people are getting glaucoma at pressures of 13. So, as I said to you at the start of the talk, glaucoma is, with glaucoma, pressure is only one aspect of the equation. But studies have shown whether or not you've got high pressure glaucoma or normal pressure glaucoma, if you reduce that pressure by about 30%, you stop people progressing in about 80% of cases. So pressure is the one thing that we can control. What pressure is adequate for you is really based on your ophthalmologist. They will have a look at your eye and make a determination of what your target pressures need to be. And that always depends on various things: where you started out, the state of your nerve where it is today, and then what it looks like, serially over time. Glaucoma is a hard disease to diagnose cross-sectionally, unless you've got bund or bad glaucoma, and we don't want to wait till you have that to make the diagnosis. But at the same time, if you start treating everyone who has a slightly suspicious looking nerve, then you're going to have a lot of people unnecessarily on treatment. So really it's about looking at people over time, which is why, as most of our glaucoma patients will know, you're often seen every 6 months or 12 months, or if we're a bit more worried, every 3 or 4 months, and looking for early change and intervening. So if you've got normal pressure glaucoma, let's say your pressure is 15, well, you might be okay if we can just get your pressures down to 11 or 12, and if that stops your progression based on all the tests you're having and every time your ophthalmologist sees you, that might be all you need to achieve a pressure of about 12. And you can sustainably do that on drops at times, provided the drops don't stop working. And sometimes that can happen over time as the receptors in your eyes become a little bit immune to the drops that you've been having. But if you've got a pressure about 12 or 11 and you've already lost a lot of field, and we know you need a pressure of about 10 or preferably even 7 or 8, you're probably not really going to achieve that on drops, and then you probably need surgery. So again, there's a lot of things at play when we try and make those decisions for our patients. Yeah. Okay, so the next question, are these surgeries available on the public system or privately funded? Yeah, look, very good question. Generally speaking, we're in a very lucky country. if you've got any sort of bad eye disease, realistically, everything should be available to you publicly, and should always be able to go to a public hospital and get treatments that you don't go blind. That's the first thing to say. Things like trabeculectomies, Bearvelt tubes and stuff, they're tried and tested. The government funds all those. You can have all those done in a public system for sure. The Eye Stent at the moment is not currently funded through the public system because the pressure reduction is very low, and the government has probably looked at that and thought that the cost of the stent for the 2mm or 3mm reduction isn't worth the cost of them funding that, when realistically people could most likely achieve most of that by taking a drop of Xalatan once a day, which, most of the time, the government funds that through the PBS as well, but, they've done sort of cost analysis and thought it's more effective to fund the drops than it is to have the Eye Stent. So something like the Eye Stent, that's covered by private health insurance. If you're not privately insured, then if you're self-funding that privately, which you'd have to go through a private surgeon for, then the additional cost of that's about $1,000 and a bit on top of whatever cataract surgery that you're having. That's just the cost of the stent. So, so it depends a bit on the device. Sometimes certain hospitals publicly will run trials of things. I know, for example, at Westmead Hospital, they were doing trials where they were doing stents for a while, or I think maybe even doing the micro shunt. Certainly the Zen they were doing for a while. Sometimes there are studies at play, and sometimes you can get access via that. But some of the newer MIGs and things, until they pass the government test of being sort of, past the cost-benefit analysis, they're not always available. But if you've got, ragingly properly high pressures and you need a trabeculectomy or something, that should always be available to you publicly. Yeah. How can a patient tell that their glaucoma surgery is failing? Are there signs and symptoms to look for? Generally speaking, no. Problem with pressure in the eye is that most of the times you can't feel high pressure in the eye, which is why, optometrists are trained to screen once yearly after a certain age for people who have high pressure, to detect early glaucoma. So if your surgery fails, and the pressure starts to become very high, it's unlikely that you're going to feel that, which is even why after you've had successful surgery, we still check you every 6 months or whatever it might be to make sure that the pressures are adequately controlled. If they fail in other ways, like if they're becoming infected or if they're starting to leak, sometimes you can get a watery eye. If they're starting to become infected, well, then you tend to develop discomfort or a red eye or discharge. I tell all my trabeculectomy patients that once you have a trabeculectomy, your risk of an infection in the eye goes up in life substantially, and that you need to be basically alert to the fact that if you develop a red eye, you get discharge in the eye, if you get pain in the eye, or your vision goes down, if you wake up and suddenly you're sensitive to light and it's painful, that you need to basically get seen by somebody that day. It's particularly pertinent if you're swimming right after the rain, when in the ocean or something where there's a lot of storm water, or you've been in a hot spring, because that little bleb site underneath your eye, it creates a portal that's a potential access inside the eye, and an infection in the eye is quite devastating and quite unforgiving. So, and we all know as ophthalmologists that an infection in the eye is basically an ocular emergency. So I tell all my patients who've had a trabeculectomy that, if you get a red eye or a painful eye, that you should basically skip, your regular GP and all that. That's no disrespect to the GP. They're very good, but they just don't have the equipment or the means to look at an eye in this capacity. So if you have a red eye, you go straight to your ophthalmologist or bare minimum an optometrist, who can then call us up straight away. Or if it's a weekend or something, you go to the emergency department where they've got an eye doctor on call, and you tell the emergency staff, I've had one of these operations and I need to be seen within a few hours because I've had this operation and now this eye is red and painful. It's the sort of thing where hours are actually quite critical. All right. What does the fluid leak from the eye look like? Can this be mistaken for tears? Yes, the fluid that's leaking from an eye looks very similar to tears. You can't really tell. And unfortunately, because glaucoma surgery is a little bit irritable anyway, you're going to get a bit of a watery eye anyhow. So there's really no really good way of distinguishing that, because if it leaks, it tends to leak quite slowly, to be honest. So I suppose if you've had surgery before and you've not had a very teary eye, and suddenly it starts to become a lot more teary than usual, it's probably worthwhile getting seen by your ophthalmologist a little bit sooner. Not quite as critical as that thing I described earlier about a red painful eye, but yeah, if you're suddenly getting a very teary eye, then you know, make an appointment much sooner, basically. Okay, I've got a couple of questions left. Okay. Oh, someone said I need to wrap up soon. Okay, I'm about to be done anyway. So last question: what point in a general sense is a trabeculectomy considered candidate of avoided altogether? I think we've kind of spoken about that at a fair bit of length. Look, you know, trabeculectomies are good operations, but they're not without their complications. They require a lot of finessing, and I prepare my patients very carefully for the fact that the next 3 months after the surgery will be a prolonged recovery. And if they have a very good one, well, then that's excellent. But I think, you know, it's worth preparing them that it's not cataract surgery where if it goes really well on day one, then, you know, we see you at a month, but generally speaking, you know, it's sort of, you can set and forget it almost. Trabeculectomies, even if you're good at 3 months, you know, you've got a lifelong relationship with your surgeon. So it's not a decision I take lightly, but, you know, the converse of that is if you're too scared to do them is that you just watch as people's fields progressively get worse and worse and they lose more and more vision with time. And by the time you decide to do it, it's too late. So it's a very fine tightrope to walk, and which is why having a good surgeon who's prepared to spend the time to talk to you about all of that, and to make that decision in concert with you, because it needs to be in concert with the patient, because we can do the surgery very well, but at the end of the day, it's the patient who lives with it for the next, you know, several decades. That's really critical and really essential. And I think that's why these sorts of talks are really important, because we all have information leaflets and we give them to our patients, but it's not often that people get an opportunity to ask these sorts of questions. And a lot of people have had trabeculectomies and hardly know what's going on in their eyes. So I think these sorts of things by Glaucoma Australia are very, very good, and I'd encourage them to keep going with them. Good. All right, I hope that's all been useful. Okay.